Hi, this is Dr. Lisa Hanson. I'm the Associate Director of the Nurse Midwifery Program at Marquette and course faculty for the Interpartum course. And I'm happy to be here today to talk to you about clinical pelvimetry. On your course materials, you'll have a handout that is from me and also another handout that includes some pictures that will make what I'm describing today in the video a little bit more clear. And these are all taken from the textbook Oxford and Foote, which we no longer require in the midwifery program. And so those are available to you as well that you can follow through. So I'm going to start by talking about the purpose of clinical pelvimetry. As nurse midwives, we acknowledge that clinical pelvimetry is not an evidence-based practice. There are no randomized controlled trials or even prospective or retrospective studies that show by doing clinical pelvimetry we make an improvement in outcomes. We don't have that evidence. But certainly there are a lot of assessments, physical assessments we make, and they don't have an evidence base. However, we know that the pelvis is one important component of the interpartum process, and therefore making an assessment of the pelvis is a part of the core competencies of nurse midwifery education. It's a part of the AMCB certification exam, which you'll be qualified for as you complete your midwifery program. And as far as we course faculty are concerned, we want you to learn clinical pelvimetry. We want you to use it at the initial prenatal visit of all of the people that you see. And then we also want you to do clinical pelvimetry on either your initial admission exam for people that are in labor or your initial or second, your initial vaginal exam when you're present. So if you don't do the admission of the laboring person, then we want you to come and do clinical pelvimetry on your first vaginal exam. Unless you're not able, it's not appropriate, the laboring woman or person is too advanced in labor and they're going to have the baby, or your preceptor doesn't indicate it's appropriate to do a vaginal exam. So as nurse midwives, we consider this an important assessment, and most of us use it to help empower the laboring woman or person, or the prenatal laboring woman or person, about the positive aspects of their pelvis that really set them up for a good place for labor and birth. You certainly can also, in the prenatal problem list, you can note concerns about the pelvis, and that's how I always use this in clinical practice. I would note, small android pelvis in the problem list. I didn't often share that information with clients, at least not initially, because in reality, a woman or a person with a small android pelvis can give birth vaginally, especially if they give birth prematurely or the baby is small. And so rather than sort of setting that person up and saying, listen, this is a big problem, you need a cesarean, we actually just try to make note of it and then notice what's going on during the labor progress. And if we notice concerns, then we think about the pelvis, especially before we consider any interpartum interventions. So I'll talk about that a little bit more when I start talking about the interpartum implications of the different pelvic types. So first, let me start by talking about the pelvis and the components of the pelvis. For some of you, this is a review. For others of you, this is your first time hearing this information. Pelvimetry is one of those things that you benefit from readdressing. And the more you use clinical pelvimetry, the better you'll get at doing it. So the first multiple times you perform these maneuvers, you might not really feel terribly much of what you want to feel, but let yourself just continue to experience it and it will come. So the pelvis is made of 4 pelvic bones. And two of them are called the innominate bones, which is a very funny name for a part on a human person, but they're nameless bones, um, and they're also called hip bones. But three parts of that includes the ilium, which is the hip bones, which you can feel on yourself right here. The ischium, the sit bones that are right here. So when you ride your bicycle and you feel kind of bruised, that's where you're feeling bruised, is right between the sit bones. And you can feel your sit bones if you feel back on your own bottom, and you can actually feel your sit bones. And then that's the ischium, and then this is the pubis. We're all pretty familiar with the pubic bone, and when you're measuring fundal heights, that's your starting point for your fundal height measurement. There's also one sacrum, which is right here, and then this model is missing the coccyx. Um, and so the coccyx is a small little bone that hangs here. This coccyx went away because of overuse of this model. And then there's also four joints in the pelvis. The first one is the symphysis pubis joint, which is right here. There are two sacroiliac joints that go along the sacrum connecting to the ilium. And then there's a sacrococcygeal joint right here. What's unique about the joints of the pelvis is they're all arthrodial, which means that they contain both ligaments and cartilage. And the beauty of the pelvis is that during pregnancy, those joints start to loosen, and pregnant women really do walk different at the end of pregnancy. And some people say they waddle like a duck. And some women actually do look like they're waddling. And that is a physiologic response to the loosening in the pelvic bones. And as you know, and you'll learn in the midwifery program, we can take advantage of the mobility of the pelvis to move the mother to help actually increase the pelvic diameters, particularly the outlet diameters of the pelvis during the labor and birth process. For example, we know that squatting can increase the outlet diameter of the pelvis by 30%. So some people call squatting the midwife's forceps. The problem is that a lot of American people don't know how to squat. So probably if we want our laboring persons to squat, they have to sort of practice. If you were born in a country where squatting is a part of life, then that person has a real advantage during the birth process. There are many people around the world that squat to use the toilet. So they squat on a hole or a particularly designed device to use the restroom, and then they have pretty much learned to squat from a very young age. So this is kind of a silly part of pelvimetry talk, but I'm going to do it anyway. There's two parts of the pelvis. One is called the false pelvis, and one is called the true pelvis. So what makes the difference between the true and false pelvis is this linea terminalis. So everything above that line is called the false pelvis. Everything below that line is called the true pelvis. If you ever did international work and you have a client that perhaps had rickets or some serious injury to the pelvis, I suppose it's possible that there could be some part of the false pelvis that could contribute to a problem with the birth process. But in this country, we really don't see that kind of problem. So our concerns are really going to be the true pelvis when we talk about pelvimetry today. And there are three planes to the pelvis. First is the inlet, then there is the pelvic cavity or mid-pelvis, and then the pelvic outlet. So I'm going to talk about each of those today, and we'll go through the dimensions that you're going to measure. Now, some of you have already measured your measuring instrument, which is your dominant hand. For others of you, you'll want to do that yourselves. I have a tape measure here that I stole from a family member. You're going to want one that measures centimeters. You're going to gently place your hand like this on the edge of a table and measure from the edge of the table to your middle finger, that length, without stressing forward, just gently touch. And so for me, that measurement is 13 centimeters. And I make note of that when I'm measuring my hand. And that is the instrument that I'm going to measure, 13 centimeters. The other measurement that I do is the side of my hand. So we take the fist and we hold it like this and we measure from one knuckle, the outside of the little knuckle, to the outside of the other knuckle, and that measurement for me is 8 centimeters. So each of you please take a minute to do those measurements. Now that you've taken a moment to measure your hand, your measuring instrument, both the diameter from here to your longest index finger, and then also your fist. So now you're going to remember those. Those dimensions shouldn't change unless you, of course, have an injury to your fingertip, which actually one of my midwifery colleagues had. But most of us, fortunately, don't experience that kind of injury. So you'll remember that measurement, and that will be your measuring tool as we go through our discussions today. So as I mentioned, first we're going to talk about the inlet of the pelvis. As the fetus comes into the pelvis, they come into the pelvis in the transverse or oblique diameter. So the baby's biparietal diameter is fitting into this anterior posterior diameter of the pelvis. So the baby's taking the most advantage of the diameter of the pelvis. And if you think of the mechanisms of labor, the baby is sort of like a key moving through a lock. And the fetus is an active participant in birth. And so they mechanically move their head to fit into the diameters of the pelvis. And the powers of the uterine contractions help the baby continue to flex and descend and move down and through the pelvis. So in order to navigate the inlet, the baby comes in at the transverse or the oblique diameter. Obviously, if a baby came in the AP diameter and that couldn't accommodate, then what we would see is the fetus floating at admission or at our first encounter with that woman during labor and birth. And there is a particular pelvic type that we see that in, and that's the platypoid pelvis. And I'll explain that as we go through and talk about the different pelvic types, but we'll bring that back a little later. So if we wanted to measure the inlet of the pelvis, the really critical measure that we want to make is this AP diameter, because we know in most of the pelvic types, this transverse diameter is quite generous. And so in order to measure the inlet of the pelvis, we use our hand. And that's our first maneuver of clinical pelvimetry that we're going to talk about today. So the person is in stirrups, and we'll assume this is a first prenatal visit. You have a glove on at least one hand. I know most of you are taught to have 2 gloves on, and that's fine. I support that approach very much. So we'll have a gloved hand, and we've now completed an examination of the ovaries, the cervix, all of the other components of our pelvic exam for an initial prenatal visit. And now we say to the person, I'm going to just gently feel your pelvic bones and see about the size for having a baby. So I reach my hand up and I measure, estimating the diagonal conjugate. In real life, what would be nice is if we could measure what's called the obstetric conjugate, which is the midpoint of the symphysis pubis to the tip of the sacral promontory. But you can't measure that in real living people. And so what we're doing with the diagonal conjugate is we're making an estimate of that diameter. And so I take my hand, I reach back, I try to touch the tip of the sacral promontory, and I have to admit, even with my 13 centimeter measurement, I rarely touch that in a real live person. And so that is an estimate of the anterior posterior diameter of the pelvic inlet. So I'm going to say right now, I'm performing the assessment of the diagonal conjugate. It's not reached at 13 centimeters, which is my estimate of the AP diameter of the pelvic inlet. And I would like you to say that out loud so that you can remember that. You're estimating the AP diameter of the pelvic inlet by using the diagonal conjugate. So we document it just that way. Diagonal conjugate not reached at whatever your measurement is. And that's your first step in documenting clinical pelvimetry. So there are a couple other things that you can actually look at when you're looking at the inlet. And one of those is the retropubic angle. So it's the angle right here. It's the front of the pelvis. We usually expect that to be at least 130 degrees. So it's very broad. There is one pelvic type where it's more sharp and narrowed, and that is the android pelvis, or nail shape or heart shaped pelvis. And we'll talk about that in a bit. Another part of the inlet, which is also a part of, has implications for the outlet, is the pubic arch. So the pubic arch we usually measure in finger breadths. And so in this model, this is a gynecoid pelvis model. I can fit 2 finger breadths in the pubic arch. And you can document it that way. Most of us don't document anything but the 3 measurements that I'm going to talk to you about today. So you can just know that is another aspect. There are other features of the inlet that are interesting. So there's the inclination of the pelvis, and those of you that work as birth workers, labor and delivery nurses, midwives, etc., know that there's certain women you have to sort of go down like you're going to the basement and then up to the 1st or 2nd floor to find the cervix. That is because of the inclination of the pelvis. So some people have a more anteriorly inclined pelvis. There's also different depths of the thickness of the bone in various pelvic types. So the more you get to know about the pelvis, the more diversity you can actually find in the women and persons that you care for, which is one of the things that I always thought was one of the great joys of clinical practice, was learning about all the interesting things that differences bring to our human species. So I think that's all I'm going to say about the inlet of the pelvis. Let's move on to the mid-plane, or the mid-pelvis, or the pelvic cavity. It's called by all of those names. So there's a lot of different dimensions to the pelvic cavity. If you look at the handouts, you can see some pictures of the multi-dimensional aspects of the pelvic cavity. So because the curve of the birth canal is a J shape, the pelvic cavity actually extends quite a long part of the entire duration of the pelvis for the fetus. And so there's a lot going on there. What's interesting is when people stand, that curve of the birth canal sort of straightens out. And so that's an interesting thing to remember. And I think for most of us, the critical thing that we're going to measure in the mid-pelvis is one diameter that happens to be the smallest. Some of the old literature calls it the plane of least dimensions. So that is the bispinous diameter. So those of you that are in the antepartum course, we've already learned how to place epidendal anesthesia, and our marker for that is the ischial spines. Those of you that are in the antepartum course or in another program that I might share this video with, who knows where you are in your midwifery program, one of the key things for us to do in labor and birth assessment is find the ischial spine. And the women or person, when they're experiencing a vaginal exam, when we feel that area, the person experiences a funny bone feeling. So it's a good feedback loop to you when you're learning. And then another thing is when you've reach that ischial spine, you'll also see this sacrosciatic notch. So the pudendal nerve runs through that notch. So when you're doing a pudendal, that's why the ischial spine is an important thing. So when you're trying to find it, you'll let your fingers sort of fall into that notch and then come forward, and that's the ischial spine. In the gynecoid pelvis, like this model, that spine is not detectable. There's nothing there. And we call that blunt and not encroaching. So if you can't feel an ischial spine, that's a good thing. And that is a feature of a gynecoid pelvis, which is a really handy pelvis to have for childbirth. And so if you don't feel anything there, but the woman feels that funny bone sensation, then everything's still fine. So then what we need to do is realize that when we're checking this, the ischial spine is at sort of 4 o'clock and sort of, 4 o'clock and sort of 8 o'clock when you're doing a vaginal exam. So as you feel the ischial spine, your hand is sort of at this sort of level when this person is in a sitting position. Some of you have worked in labor and delivery and haven't really probably always used the ischial spine as a marker for station, but I would encourage you in the midwifery program to do just that. And that means that you will, when you're doing a vaginal exam, you're going to actually find that ischial spine and then measure that station using that spine. And we know that that station at the spine, when the presenting part is at the ischial spine, that's a 0 station. If the fetal presenting part is above, like let's say 1 centimeter above, we know that's a -1 station. If that fetal presenting part is 1 centimeter below, we know that's a +1 station. And I would like you to carefully document that as such in your notes. And if you haven't had a chance to refine that skill by working in labor and delivery, this is your time to start finding spines and be very systematic about that assessment. So we're going to measure the bispinous diameter, and that is the space between the ischial spines. And we know that the biparietal diameter of the fetal head is on average 9.25 centimeters. And so it makes sense that an adequate bispinous diameter is about 10 centimeters. I know from years of clinical practice that this is what 10 centimeters feels like to my fingers. So I can place it there, and I know that this bispinous diameter is greater than 10 centimeters by my estimate. So therefore, we've done 2 assessments. We feel the character and quality of the ischial spine just by palpation and location. And then we measure the bispinous diameter. And what we're doing is we're estimating the smallest transverse diameter of the mid-pelvis. So let's say that together. I'm going to estimate the bispinous diameter, which is the transverse diameter of the mid-pelvis. Now we're going to move to a discussion of the pelvic outlet. Outlet is an amazing diameter of the pelvis, and of course as a midwife I love this part of the pelvis, and as a second stage researcher I really like it. So if you look on your handout, this page has pictures of the pelvic outlet, which I'm just kind of adore. And you can see on the top diagram the pelvic outlet is really diamond shaped, or it's 2 triangles, and the base of each triangle is this diameter. So these are the sitting bones or ischial tuberosities, and this is the base of the triangle. So one triangle is this one here, which is actually the symphysis pubic arch rather, and the other triangle goes to the tip of the coccyx, and that is an important triangle as well. So we know that the baby So the baby comes in the pelvis transverse oblique. At the level of the ischial spines, that baby makes an internal rotation, and then the baby's born by birth by extension in the OA position, so that head comes up and through the pelvic arch, and so this diameter is critical for that. Obviously, if the baby comes out OP, it's birth by flexion, and then obviously this part of the triangle plays a greater role. So in order to estimate the transverse diameter of the outlet, we use that measurement we did of our fist. Mine is 8 centimeters. And so once we've taken our gloved hand out, we press with our non-dominant hand in the top of the woman's or person's thigh, and we feel the ischial tuberosities, and then we take our fist and we rest it there, and just to make an estimate, and I document that that is greater than 8 centimeters. And so that's the final step in clinical pelvimetry. So we document that outlet transverse diameter greater than 8 centimeters. So let's review all 3 maneuvers that we've learned today with our measuring tool. The first, to estimate the AP diameter of the inlet, we estimate the diagonal conjugate in this very gentle maneuver. In this example, that is not reached at 13 centimeters. So diagonal conjugate not reached at 13 centimeters, how I document that. Then I gently move my fingers down to the 8 o'clock position, feel the character and quality of the ischial spine, and then I estimate the bispinous diameter, in this case, greater than 10 centimeters. I'm sorry, greater than 10 centimeters, because that's my reach here. And then I remove my hand from the vagina. I feel through the thighs, feel the tuberous prominences, and I'm going to use my fist to estimate the bituberous diameter as greater than 8 centimeters. And I'm going to document those 3 characteristics of clinical pelvimetry in the prenatal record. So those are the 3 features of clinical pelvimetry that I would like to encourage you to remember and practice in clinical. Now, especially for those of you that are in the intrapartum course, I'd like to talk a little bit more about how the various pelvic types have an impact on labor and birth. So you've all either completed or in the process of completing the worksheet on clinical pelvimetry. This is really there for you to learn the details of the various pelvic types. They're listed on the top, and their shapes, and what they are is actually the shapes of the 4 pure pelvic types. In midwifery school, we won't ever test you on mixed pelvic types. We'll test you on only pure pelvic types. In reality, in clinical practice, we have a pretty heterogeneous population in the US. There's people of different backgrounds and ethnicities that marry or procreate, and so pelvic types are very mixed in many people, and so you know that some people will have a tendency towards a couple different pelvic types on their measures. So I'm sure there are people walking around with pure pelvic types, but there's certainly as many people that have a mixture. But remember, we'll test you only on these pure pelvic types. So let's talk first about the gynecoid pelvis. That's our model here. So the gynecoid, when you look at this pelvic type, you can see that it's really a round inlet. So it's nice and round. This is a very handy pelvic type for having a baby. The baby makes a very early and complete internal rotation, and it can fit easily out through this outlet diameters, and there isn't a lot of damage to the perineum generally. So when you think about perineal outcomes and you are in midwifery school trying to promote intact perineums, know that sometimes some of the tears that occur are really a function of the pelvic type. It's not always, maybe you could have done something different with your hand maneuvers. Although obviously we want you to take great care in learning various approaches to hand maneuvers. The next pelvic type I'd like to talk about is the anthropoid pelvis. That word means ape shape. That doesn't mean anything negative about people that have that. It's just sort of primate pelvis, and we are all primates, let's face facts. And so that oval shape actually is not such a problem for childbearing. So most of the sources that you look at that look at clinical pelvimetry, which I hope you'll take a look at various sources, know that many of them say this is perfectly fine, especially if it's a generous size pelvis. And so one of the features that can happen with an anthropoid pelvis is sort of more occiput posterior fetal position, and that can actually make for a difficult labor for the laboring person, more back labor, somewhat prolonged in some aspects, certainly not always. And so then if the baby in the occiput posterior position has two options. One is a short arc rotation to direct OP for birth. The other is a long arc rotation to an OA for birth. And that's one of my favorite things when I would see that happen, that long arc rotation just before the baby was born. I always thought it looked like kind of a miracle as that little baby was turning its head to come out OA. It's just a beautiful thing. So that's probably what most of the sources say about anthropoid pelvises. Let's next talk about, on this sheet that I have, the next pelvis is a platypoid pelvis. And if you think of a platypoid pelvis as a compressed gynecoid pelvis, it's like taking this model and pressing the AP diameter to make it shorter. Classically, and I know there's some variation in sources on this, but classically, the platypoid pelvis can be problematic for labor and birth. Classically, what we see is the person comes in for labor and birth with advanced dilatation there, 8, 10 centimeters, but then you feel a fetal presenting part that's -4 blottable, which is sort of a disconnect. And one of the things to think about is, could this be a platypoid pelvis? That baby can't even make it into the inlet of the pelvis. And so sometimes those women or persons end up having a cesarean for failure to descend. And that's pretty classic with a platypoid pelvis. So what you would feel on pelvimetry is you would actually very easily run into the sacropromontory when you're doing the diagonal conjugate measure. You run into it. And when I've had those experiences and noted it on the chart, inevitably many of those women have needed a cesarean. So especially if it would be associated with something like short stature. So I mean very short stature. I mean a person that is very small or almost a little person, but sort of there's gradients in between. There is some old literature on height and bones and gait and stance and all that stuff, but most people don't look at that literature anymore. But certainly there are a series of articles that have been written about height and shoe size related to pelvimetry, and I haven't done a recent review of that, but I just wanted to share that, there's other things you can sort of capture when you have someone that has a small pelvic diameter like that. You want to ask yourself, what is her height? You might even ask questions about her mother, sisters, if she has sisters that are similarly built. And, as I said, you don't necessarily want to disempower women because it is possible she could give birth vaginally, especially if she gave birth early or to a small baby. So, again, all data to collect. Those of you that will take courses for um, surgical first assist after you complete the midwifery program, that's not a part of basic core competencies, but many of our graduates take those classes. Some of you will actually be able to see the pelvic diameters during the cesarean, which is, I hear, really interesting. I have done some first assist and certainly surgical assist for cesareans, but I never really got a chance to really look at the pelvis. But some of my colleagues have shared that with me, and I think that would be very interesting if you had a client you were working with that had a cesarean and then you could actually see the pelvic inlet. It would be pretty exciting. So most of the other features of the platypoid pelvis are sort of on the wide side. The good news is the platypoid pelvis is a relatively rare pelvic type. It's only about 3% of all people that come to labor and birth. So that's the good news. The final pelvic type that I'd like to discuss is the android pelvis. So it's final on this sheet, which I think is the same as yours. And the android pelvis or male-shaped pelvis is probably the most problematic for childbearing. And that doesn't mean childbearing can't be successful. It just means that it might have some challenges for the laboring person. So the inlet of the android pelvis is heart-shaped, and that's the way males' pelvises are shaped, is in a heart shape. And you'll see those sort of in, anatomy labs all around campuses. You'll see examples of the male pelvis in those examples. And as we know, males tend to have smaller hips than females. So people with android pelvis can be kind of smaller in the hips. Now, that doesn't mean that you could do clinical pelvimetry by looking at someone, but I'm just trying to give you an example of the differences. So the interesting thing about the android pelvis is certainly it's not, unusual for women to have that pelvic type. Maybe 30% of the population has sort of a android type pelvis. So clearly, people with that have been able to procreate and have children. But it can be a challenge, and I'm going to explain some of the challenges. So the inlet is a problem, but usually the fetus can sort of get into the inlet. Where the real problems start to happen is in the android pelvis. I didn't explain, but in the other pelvic types, most of the time the side walls are straight in the pelvis. So as the fetus moves down the pelvis, the diameters sort of stay the same. In the android pelvis, the side walls are convergent. That means it's a little bit sort of cone or funnel shaped. And so as things go down in the pelvis, they get smaller. And so the big problem with the android pelvis starts with the bispinous diameter. So at the level of the ischial spines, the baby comes at the transverse or oblique diameter, gets to the level of the ischial spines and needs to move to internal rotation. And at that point, sometimes the fetus stalls in what we call deep transverse arrest. So the baby's stuck in the transverse diameter. We can feel the sagittal suture is transverse. In order to have a successful vaginal birth, the baby has to do the internal rotation. Now, there are times when you'll find this, and perhaps the contractions are not as frequent as you think you need to have adequate labor and have a successful vaginal birth. So you might order some oxytocin to stimulate labor. And so you try to help get more contractions to help rotate that baby. And granted, the baby could rotate into an OP position, but at least you'll get it out of the transverse arrest. And what happens in the sort of more extreme cases is that rather than the fetus rotating, you'll end up with suspected fetal compromise or fetal heart rate decelerations. And so sometimes it's a sign that the baby can't tolerate our attempts to help, establish adequate labor and get a vaginal birth. Now, if you can get the baby to rotate and the baby moves further down the pelvis, you'll generally, at the level of the ischial spines and beyond, you'll generally start having significant caput and molding. Obviously, you can have molding and caput in any of the pelvic types. It's probably going to be more extreme in the android type pelvis. And so that makes assessments more difficult. We always want to feel for actual bone rather than assessing caput. And what I've noticed in my career is sometimes you can feel and think someone is 8 centimeters. And what we sometimes do at more advanced dilatations is we feel how much cervix is left with one finger rather than feeling with 2 fingers and seeing how much of the cervix is open. And I would encourage you to do both, especially in situations where labor has been difficult. I want you to feel how much cervix is open and how much is left. And in an android pelvis, sometimes you will think you're getting progress, and what you really have is no progress. And the cervix just sort of funnels down without real progress. So I would just encourage you to try to learn from that. Sometimes, even as a very experienced birth attendant, I would sometimes just measure my own fingers to maintain my objectivity, especially when I've been with someone for 30 hours. You can get really tired. So how much dilatation do I really have on this particular woman? Is this really progress? And certainly we know from the current labor progress literature that even a 0.5 centimeter of progress is progress. So we want to be very careful in our assessment. So that once that baby with the android pelvis makes it through, and granted, many do, we still have more problems potentially. So we can get the baby down through the pelvis. It's probably been a slow progress. And then that baby is going to have sometimes the need for an instrumental vaginal birth, forceps or vacuum, sometimes a lot of perineal damage. So with the android pelvis, it can be difficult for the labor and birth process. And sometimes if the person needs an episiotomy because we're trying to get the baby out and the tissues aren't moving, or there's suspected fetal compromise, sometimes that'll extend into a 4th degree laceration, for example. And so that's some basics about the interpartum outcomes. I would encourage you to look at the various sources that have been made available to you and do your own comparisons. What I would recommend for studying this very complex topic is I would recommend using the sheet, and I would take a yellow highlighter and I would highlight the unique features of the pelvic types across. So when you look at something like the ischial spines, for example, which of the pelvic types has ischial spines that are prominent and encroaching? And that is the android pelvic type, and that's where the baby can get caught at that 0 station and transverse arrest, for example. So look at commonalities and differences, and that will help you as you study this content. I hope that you've enjoyed this video, and I hope that this will contribute to your learning and that you can watch this again. Thank you and have a great day.